Good afternoon, and thank you for joining me for another Leadership Rounds. I'm Dr. Mindy Estes, President and CEO of the St. Luke's Health System in Kansas City, and the Chair of the American Hospital Association's Board. This week, I'm pleased to introduce Kevin Sowers, President of Johns Hopkins Health System and Executive Vice President of Johns Hopkins Medicine. In these dual roles, Kevin oversees the health system's 6 hospitals. He also serves as chair of Johns Hopkins Community Physicians, which has more than 40 primary care and specialty practices throughout Maryland and the Washington, D.C. area. Before joining Johns Hopkins Medicine, Kevin spent 32 years with the Duke University Health System, starting as a staff nurse in oncology and ultimately serving in faculty, nursing leadership, and senior leadership positions. He is a current member of the Vizient Board of Directors and the AAMC Council of Teaching Hospitals and Health Systems Administrative Board. Welcome, Kevin.
Thank you, Mindy, for having me with you today.
It's a pleasure. Now, shall we just jump right into it?
I'm fine with that.
All right. While COVID-19 has certainly presented us with a number of challenges this year, I think for longer than any of us anticipated, it's also afforded new opportunities to rethink the way we deliver care and how our patients can access it. Are there any new strategies or innovations that Johns Hopkins Medicine has employed to not only address COVID itself, but also help improve care for patients overall?
You know, Mindy, I think many of us have learned many valuable lessons, but some that I'll just speak to. Number one, I think telemedicine took a huge leap during this pandemic in a very positive way. We went through from a couple hundred visits a day to now doing over 5,000, 6,000 visits a day. Now, while it might not work for every specialty, for instance, psychiatry feels that the in-person, in-touch first visit might be more appropriate, and then follow-up visits with telepsychiatry might be helpful. Dermatology is another area. But for post-op, for primary care visits, for well visits, it really has served us well. I think one of the things we're going to have to address as a nation and as an industry is while we've been able to do this across state lines during the state of emergency, we are going to have to deal with credentialing issues and payer issues as we continue to look at this into the future, because it really has helped us transform healthcare. And in that, we've also looked at how we also need to think about our facilities different. Will we need waiting rooms in the future? Will we build our outpatient ambulatory centers to have banks where we will do telemedicine within the facilities? So I think there's that piece. I think the other piece that has really transformed the way we think about delivering care is really a lot of our functions that we now have people working from home. Will we need the same types of facilities moving forward? Or will we keep a part of our workforce at home, our non-clinical workforce, that still is an important part of the team in delivering healthcare? But will we need to train our managers differently on how to manage people from a home setting, and also setting productivity measures and managing them more differently? I think the other thing that as I look to the future is how we will use technology at home to monitor patients, and how we will build hospital at home programs, which we have done here at Hopkins very successfully, but really expanding that even more as we think about keeping people more in the home setting and being able to monitor them at home. So those are some of the what I would call macro trends that I see for all of us in the industry having to think about right now as we learn from what we've experienced during the pandemic.
No, thank you. I mean, it's very clear we have learned a lot of lessons over these last 9 or 10 months. And it's interesting to me how in different areas of the countries and different organizations, our psychiatrists embrace telehealth. Our neurologists are hesitant. So it varies among groups. Hopkins is an institution that is known for research. Share with us how your teams have been engaged in fighting COVID And are there any studies underway or recent findings that could be applicable to our larger audience?
We now have over 200 research studies that we're in progress. And I would say that it is everything from basic science studies all the way up to clinical trial studies that are really looking at the clinical care of some of the evolving drug therapies that are in place. But we are also a part of the international group that's looking at the transformation of the virus and looking at how it's evolving as we go through this pandemic. So our researchers are hard at work trying to not only think about the basic science behind how the virus is transmitted and other elements of the virus, but also how we can treat the virus. We are doing vaccine trials. We actually have set up research pods in parking lots where patients can drive through and participate in COVID studies. So there's many unique ways we've engaged our community in research, clinical trials, and basic science trials as we've gone through this pandemic.
You have a large international presence. Are there any lessons learned from experts at your international locations?
You know, Mindy, we've really stayed in contact with a lot of our global leaders around the world to really understand what are the evolving best practices that people have experienced. So, one example, and I think we've all learned this now, in the beginning of the pandemic, when you saw someone's O2 sat drop below 40%, for most providers, that was a time when we would immediately intubate, but we learned very quickly that if you put somebody on 6 liters or more, that goes up very quickly and returns to normal. So, decreasing the amount of intubation that we might be seeing in our population. We saw that lessons learned in Europe early on and in Italy from our colleagues there. And now, as we see a second surge appearing, we can apply that lesson learned to this population. The use of dexamethasone is another example of a lesson learned in treating some of the pulmonary complications. What I think, Mindy, we have still got to grasp as we look at the back end of this pandemic is, and as I'm sure it's true for you and many of our providers across the country and around the world, is what are the long-term complications for COVID patients that survive? We've seen cognitive impairment, we've seen heart complications, we've seen pulmonary complications, we've seen kidney complications. So will we need to have post-COVID clinics to really care for these patients who have survived the illness and the severity of the illness in caring for their post-clinical sequelae that they've experienced because of having COVID? And I think that's where we need to begin to start to focus some of our energies in understanding how we're going to respond to those needs, especially as we watch the numbers continue to increase around the world.
A really good caution. As you were talking, my mind went to, the 1918 flu pandemic, and we certainly saw neurologic complications, well after the fact. I mean, in some instances, several years. So I think your point is well taken. Safety is always of the utmost importance, and as a field, we are committed to employing practices and protocols that keep our patients safe. But we know the public has expressed concerns about safety during the pandemic. Can you share any new or perhaps particularly effective strategies that you've employed this year to further protect the health and safety of your patients?
Well, of course, we all have been at the forefront of assuring that masking, social distancing, and hand washing are key. But in the healthcare setting, PPE becomes a very important part of our safety measures. What I would say, Mindy, that's been one of the challenging parts, I think, for all of us is actually the balance between the public health paradigm that you have to respond to during a pandemic and patient and family centered care. When I
Mhm.
look at visitation policies and trying to make sure that we balance both of those, it has become difficult. And so, together with our PFAC, our Patient and Family Advisory Committee, we helped develop a policy looking at a variety of metrics that would allow us to collectively make decisions on when we would begin to limit visitation within our hospitals or open back up to one caregiver per patient per day. Because what we began to realize is the balance of that and getting the public and our patients and their loved ones to understand was critical. And so that partnership, I can't speak enough to in terms of developing that dashboard that allows us to do that. Um, we are set on PPE right now, but as I begin to look at the evolution of, because we've tried to stick to the science, but when I begin to look at some of the evolution of what people are now asking of us to take temperatures at the front door of your hospital. Well, we all know that we can take the temperature, but somebody could still be asymptomatic. So the temperature taking really is not a scientific method. If somebody does have a temperature, yes, they should stay home. But taking the temperature is not a true screening tool. Asking the questions at the front door and the questions of our employees. While we do that every day, we are entering into a season where there's sinus infections, flu seasons. So being able to have OC Health stood up and being responsive to the symptoms that people may have to assure that we are able to rule out those symptoms from true COVID diagnoses is critically important in terms of safety measures. So we've had to really beef up our health strategies within the enterprise. I would tell you, Mindy, the number one thing that I am most concerned about from a safety standpoint is the health and well-being of our care providers. When I round on our COVID units, I see a level of moral distress, and the reason being is these are folks who are on the front line and are incredibly serving as heroes in my mind. But at the beginning of the pandemic, it was their own fear about getting the virus, and then once they understood their protection of PPE, it evolved from their safety to their family safety of going home, and heard stories about people who take their scrubs off before they enter the house and put it in a plastic bag
Yep.
and put it in the washing machine and make their way upstairs and shower before they hug or kiss their loved one. And then you started to hear about the concerns about the health equity issues. And so for our employees who are underrepresented minorities, it was kind of a double whammy. There's COVID, and then I'm losing loved ones in my community who, because we know that African American men die at a much higher rate than any other demographic in our population, and the Latinx population has a higher positivity rate in our community than other demographics. And then on top of that, we've witnessed the social injustice that's occurred in this country. And so when I look at this, I look at a layered cake that there's multiple layers that we have to pull back to understand what our workforce is experiencing. I'm sure this is true for all of us, but we've seen a 26% increase in mental health admissions for our providers across our system. We've seen 1,300 employees and faculty go on anti-anxiety and antidepressants who have no history of mental health issues and or any history of taking those meds. So one of my number one priorities for Johns Hopkins Medicine is assuring that we have strategies in place to care for our providers, because without having a healthy workforce, both physical and mental, it can lead to other safety issues for us. So for me, it's a critical part of what I think we all need to be thinking about right now is how we care for one another during this unprecedented time in our history.
I certainly appreciate that. Very well said. I mean, I have looked at this pandemic. We focused on supplies, we focused on testing, but staffing and the resilience of our care providers and the great stress that they're under is top of mind. And as this has continued on, well said, it has become prolonged and even more difficult. Kevin, thank you again for joining me today and for sharing your insights so that we could all learn from each other as we work to improve the health of our communities. I invite you to mark your calendar for our next leadership rounds on November 19th, where I will be joined by Sarah Crevens of Sutter Health. Until then, be well and stay safe. Thank you.
Thank you, Mindy.